Thank you very much, firstly, Magda. So a pleasure to be speaking to you today. So there is a huge need to inform the public and most importantly, to inform policymakers about how big a problem familial hypercholesterolemia is globally. And there are many different ways of trying to do that. So what has happened previously is that largely Western, North American, European studies have been done whereby you go out into populations and you make some estimate of the number of cases. Now, if you think about the world having more than 7 billion people, they provide a snapshot from different regions of the world. And as you can imagine, under diverse living circumstances, the WHO regions, there are regions of the world where we don't have much information. And what you can do is do something called a meta-analysis. So you don't need one giant study of 700 or let's say millions of people. You can collect published data, provided the data is in a similar sort of format, analyze the data, and you can pool the data. So you can look at individual studies and look at the pooled effect and the statistical models that allow for that. And that gives you the opportunity to look at how consistent or inconsistent some of these data are. So that is what we've done to really, in the general population in particular, where we don't have specific families like Afrikaans or French Canadians, where there's a founder effect, where FH is much more common, really asking the question, if you went out and you were going to screen, for example, a general population, how common is this condition? And so the magic number is 1 in 311 people are likely to have FH, which means that is 0.32%. And the reason that this becomes really important, it's much more frequent than the previous calculated estimates of 1 in 500, for example. So it has huge implications for public health. The second thing that we did was we looked at these people, and there's just over about 42,000 individuals who have vascular disease. And, in FH, we are concerned about early disease. So we often get a hint of it when your father, mother, a family member, a first-degree relative has this history early in life. So when you look at that number, I think that number basically now is more like 1 in 17, meaning it's likely to be much more common. And so if you think about coronary care units around the world, for example, that serves as a really good source of finding potential patients for cascade testing. The average is 1 in 311. If you look at the range where it could be as low as or as high as, and that gives you the consistency, it could be as frequent as 1 in 250. It could be less frequent and as high as 1 in 397. So still less than 1 in 400. If you basically look at studies published before 2000, the prevalence is about 1 in 400. And if you look at studies after 2000, it's 1 in 256. And perhaps it's using slightly more specific tests, it's using more genetic assessment. But I think using the average probably works reasonably well. At this sort of scale, we've made the point that it's more common than previously thought. The way that the screening committees think about a lot of these things, they usually, particularly for childhood screening, they think about conditions. If you think about the blood test that you would have, the heel prick, all of those conditions, the way they think about this is that if you did not, even with really rare conditions, if you did not find them, the conditions would have such an adverse effect in such a short period of time that it mandates the need for testing. So that's kind of their thinking. However, because FH, unless you've got homozygous FH, in which case it's catastrophic in the first decade of life, unless you have homozygous FH, which is the heterozygous FH, the consequences of that will probably be in the third, fourth, fifth decades. It's still premature disease, but longer. And I think that what the screening committee potentially missed an opportunity with is because kids going through school, pre-university in many regions of the world have opportunities for interaction with healthcare. And I think, for example, with the advent of genetic testing, point of care testing, that's an opportunity to screen. I think the costs are likely of that approach are likely to keep dropping. I do not think they're certainly by any means unaffordable. And I think what we do need is potentially, whereas individual countries are interpreting all of this in different ways, we actually do need the WHO, for example, who I gather may or may not be looking at cholesterol updates in the next iteration, to have a simple message: universal screening for cholesterol before the age of 20 around the world. That will help the large number of people that yet to be or yet to undergo screening who are under the age of 20. It doesn't, for example, impact the people living with FH who have missed that opportunity and who will either present because of concerns or worry, or with a cardiovascular event. So we need a different strategy there. Some may be picked up, for example, with electronic health records and opportunistically, and we might need to think about AI and algorithms and big data, for example. So that is one approach. The next thing is when you have a heart attack or premature manifestation of vascular disease, we need to actually design algorithms whereby it shouldn't be an afterthought that this person could have FH. You should start thinking about, and that way we can go and either exclude or find and then cascade test. So I think there are three different approaches that are needed, and I think it's fairly simple in that regard. What we now need to do is really get patients, scientists, doctors involved in this, patient advocacy groups, and policymakers together and say, right, enough's enough. Let's recognize we're not going to try and do this in 6 months, but in the next 5 years or so, can we not do better than we are doing right now? First thing is that familial hypercholesterolemia is common. I think everybody should have had a fasting cholesterol check and a look at their LDL cholesterol measurement at least once in their life. That would be the second thing. And the third thing is, if you've got a family history of heart disease early in life, or you yourself have had heart disease early in life, and you have not been tested for FH, you should.